Hello, and welcome to the Practicing Clinicians Exchange podcast titled Improving the Co-Management of Moderate to Severe Pediatric and Adult Atopic Dermatitis in Primary Care and Specialty Settings. I'm your host, Tori Garcia-Albea. I'm a nurse practitioner, and I'm the director of the Leahy Dermatology Nurse Practitioner Training Program at Leahy Hospital and Medical Center, which is in Burlington, Massachusetts. With me today is the one and only Dr. Jonathan Silverberg, professor and director of clinical research and director of patch testing at George Washington University School of Medicine and Health Sciences in Washington, D.C. This program is supported by an educational grant from Sanofi Genzyme and Regeneron Pharmaceuticals and is developed in collaboration with the National Association of Pediatric Nurse Practitioners. For more information about this program and to access the CE certified recorded roundtable webcast, downloadable slide set, and clinical thought commentary, please visit pce.is/atopic, ATOPIC. So let's get started. We have several new agents and updated FDA approvals available for the treatment of atopic dermatitis. Let's discuss a few of those.
The JAK inhibitors are really, I think, the wave of the future in many respects. So we're just going to keep seeing more and more of them and different types and different combinations, et cetera. For atopic dermatitis in the US, we've got now 3 new options available. We've got one topical with topical Ruxolitinib as a cream. And then we've got 2 orals, which are Abrocitinib and upadacitinib as oral JAK1 inhibitors. So topical Ruxolitinib is a so-called JAK1, JAK2 inhibitor. And, on paper, this is arguably the most effective non-steroidal topical agent we've got, and in a cream format that's generally speaking very well tolerated. My experience has been quite positive with it in the real world, and it's a little pricey. It's not always easy to get access to. But from an efficacy standpoint, it is great. Probably the biggest challenge that we navigate is that how things have evolved in the United States with JAK inhibitors is that the FDA has now assigned class-wide, black box warnings to anything that mentions the word JAK in it. And even if it was never seen in the trials. So, this topical agent has these very scary theoretical black box warnings that never happened in the trials. We don't really think it probably ever will. But at the same time, it's something that needs to be very carefully addressed with patients, because if we ignore it and we don't tell that to them and poo-poo it, they're going to go to the pharmacy, they're going to hear about this, and they're going to think that either we don't know what we're talking about or we're ignoring them. Yeah. But I think overall the safety is quite good for these drugs, especially when used on more limited body surface area.
Let me ask you a quick question about the topical Ruxolitinib. Are you using it instead of a tacrolimus or a pimacrolimus, or are you kind of fitting it in after you might have failed those?
It has actually become my go-to non-steroidal at this point.
On eyelids too? Have you had experience on eyelids?
Eyelids, face, genital, intertriginous areas, all of those sensitive skin areas where I previously would have used tacrolimus or topical crisaborole or even pimacrolimus, and I still use those in different situations. But the nicety for this one is as a cream and a fairly rapid acting one, and one that's, from the phase 2 data, more effective even than triamcinolone cream. That profile is a very appealing one.
And I believe less irritation than some of those other topical non-steroidals.
Correct. And I've seen some irritation in the real world. I don't think any topical agent is going to skirt that completely, but it is definitely far better tolerated than many of the other non-steroidal topical agents we've previously used.
We have experience discussing black box warnings with our patients or their caregivers with those topical calcineurin inhibitors. So I think, reassuring them, like what you said before, that the FDA labeled this cream with the warnings about the pills. I think patients understand that, but have you had patients or families that were unwilling to use one because of that black box?
Yeah, and understandably so. This is, I think, part of that shared decision making. Patient has to be comfortable with it. But we've had patients say no because especially they feel like, maybe they're not quite as severe, or they've maybe used some of those other nonsteroidals we've discussed in the past. Maybe they'll say, well, okay, it'll take me a little longer. It may not work as well, but I'd rather use the tacrolimus or use the crisaborole. In particular, I think for those risk-averse patients, topical crisaborole offers that really cleanest safety label, the approval down to that younger age group. So I think that crisaborole becomes the winner in that situation. But crisaborole is a thicker ointment, which may be less appealing to put on the face during the daytime because it's a little bit more, visually apparent, and it can sting a little bit more. So you've got options which are nice, and different patients will choose differently based on their own preferences.
One little tip is just to put that crisaborole in the fridge. I find some patients have less burning and stinging if it's cold.
Absolutely. Yeah, I mean, there's always that what if it alters solubility in some way? But my experience has been exactly like yours. I recommend it to all my patients. We don't want to freeze it or boil it, right? You don't want to go to the extremes of temperature, but keeping it in the fridge, it really can help. And the truth is that pearl works beautifully for all topicals, even for topical steroids.
True. It can be so soothing.
Absolutely.
I was going to just ask you, is there any person with a possible comorbidity where you would not use a topical JAK?
So I think it's a good question. For me, I pay close attention to the trial design. And there we see a body surface area restriction to the lower end of the body surface area restriction, right? So you had, I think it was between 5 and 20% BSA range in the trials. Mm-hmm. And so I respect that. I mean, first of all, it comes in a 60-gram tube. So you couldn't put it on someone who's got 50% BSA all the time anyway. But I think when we look at some of the absorption studies and pharmacokinetic studies, when it's used on more extensive skin, more extensive lesions, there we can see a little bit more absorption. So if I'm talking about, up to 5-10% BSA, I really have no qualms about using it in any patient in those situations because there's really would be such negligible absorption. I don't foresee any real safety concerns coming up. If we're talking about a patient with, above 20% BSA, let's say arbitrarily, I pick 50% BSA. Mm-hmm. That's a different situation. And that might be one where there might be a little bit of absorption that happens. And whether or not that will be problematic, it's hard to say. But if the patient has, a known history of blood clots, of DVTs and pulmonary embolism, and they're going to be using this on 50% body surface area, that's probably not the optimal patient because we do know with systemic JAK inhibitors, it's a rare but serious event that could happen with the class. But for limited body surface area, my sense of and my read of the data is we really don't have too much to worry about.
Well, that is a good segue into talking about the orals because, we were talking a little bit about systemic absorption to the point that you're getting side effects. So let's talk about upadacitinib first. So this was recently FDA approved for atopic dermatitis. Have you had some success with this one?
Yes. So I've actually been working with upadacitinib since 2019 when it was first approved for rheumatoid arthritis, and it was available at that time off-label for atopic dermatitis. And we've gotten the approval in January of 2022 now for atopic dermatitis. This is approved for moderate to severe atopic dermatitis who've already failed, not only previous topical therapy, but the FDA has advised their use in those who failed or have contraindication for prior systemic therapies as well. On paper, upadacitinib at the 30 milligram dose really sets the bar for efficacy in the field, period. Better than what we've even seen in the trials for prednisone and cyclosporin. Now, the recommended dosing is not to start with the 30 milligram immediately, but to start with the 15 milligram first. And if they have an adequate response, you can keep them on the 15. If they have an inadequate response, then you could consider increasing to the 30. And that's, the idea to potentially mitigate risk concerns with the class. Upadacitinib was really a highly effective medication that has worked in patients who have failed I mean, literally everything. We've had patients come in on combinations of dupilumab, omalizumab, and cyclosporin, not controlled, and be able to manage on upadacitinib monotherapy. But as we alluded to earlier with the topical JAK inhibitors, while we don't think the topicals come with some of the class-wide labeling issues that the FDA assign, the orals do. And so upadacitinib does have a number of black box warnings. Some of them are also inherited class-wide. Some of them didn't happen necessarily in the trials clearly. This is an important conversation that I do have with patients. And I try to frame it around this idea of rare but serious risk. And not to trivialize it, but also for them to understand we're talking about, 1% or less for some of these. And if we're choosing our candidate patients wisely, it might be less than 1 in 1,000 where we really encounter any of these serious adverse events. So very effective medications. They're oral, very rapid. There's the opportunity for dose flexibility, but, complicated by the need to discuss a lot of these safety concerns.
I agree. I find that when you have an appropriate patient, they're an excellent choice, but it is a conversation. And unfortunately, many of the patients that I'm personally considering for these medications are very frustrated with their disease and lack of control of it. So I think they're, a little bit more open to something that's newer. Again, low risk of having a side effect, but with a serious potential side effect.
Right. Just briefly to discuss abrocitinib, very similar profile overall to upadacitinib. So I think everything that I've mentioned pretty much holds true. It's also a selective JAK1 inhibitor, also an oral once daily, also approved with 2 doses, but a recommendation to start low, which is the 100 milligrams, and then go up to 200 if there's an inadequate response. And a similar kinetics profile and efficacy profile overall. On paper in the trials, maybe slightly lower efficacy than upadacitinib, although it's impossible to really say anything with confidence given that they're different trials and we don't have head-to-heads between the two. But also a highly effective medication. Similar labeling concerns, and there's a few more contraindicated medications in terms of platelet inhibitors. But other than that, really also an excellent drug and another good option to think about.
How do you determine whether to prescribe abrocitinib or upadacitinib?
That's a great question. I don't yet have a great way of figuring out why one patient might do better on abrocitinib than upadacitinib or vice versa. For me, right now, I have 2 great options. And in a sense, it might be the insurance that dictates which one I choose, depending on what's on formulary or what I have access to, which I hate for that to be the deciding factor. But when you've got 2 very comparable drugs, I don't necessarily mind either following the insurance company's lead.
All right, let's move on to dupilumab. It's very exciting. It just recently received approval by the FDA for treatment in patients with moderate to severe atopic dermatitis, ages 6 months and up. So this is a biologic. It's an injection medicine. This is very big news for our younger patients. I know there is a lot of discussion around whether we should be using this medication in such young children. Have you had any patients that young on it?
I have. So my youngest patient that I started on dupilumab was, I think, 4 months at the time. That would be off-label even now, but it was certainly off-label then. But, had I waited the 2 months now, that would be considered on-label at age 6 months and up. We don't pull the trigger to go to a systemic or biologic agent willy-nilly. The efficacy has looked great. The safety has looked great over the past 5 years with really, very few, if any, new safety concerns emerging in 5 years post-marketing, which is, I think, a big deal and a rare scenario in healthcare. But there's always that what if, and so I don't know what might we discover 20 years from now that we don't know. So I don't push it certainly unnecessarily. On the other hand, we have patients that are just, suffering. I mean, the families are suffering and they're not sleeping. They're not functional. And those younger kids, when they get bad atopic derm, it's the most inflamed lesions possible with oozing and weeping and cracked open skin and erosions and the pain. And they're fussy and they can't thrive. They're not growing. They're not eating. No one in the home is sleeping. And you've tried the topicals and nothing is working, even potent topicals. At that point, what would you do? Previously, we had literally nothing. And now we've got a great new option. Sure, it would be nice if we didn't have to use a shot. But at the same time, it's not a once daily shot, right? We're taking this now spread out by many weeks, which makes it a lot more manageable for parents and for patients. So it's a careful conversation we have to have with the families, but it's really a great option for a lot of patients.
I agree. And, for primary care providers out there, if you're struggling to get a little baby under control, don't hesitate to refer, because like Dr. Silverberg mentioned, if the baby's miserable, the whole house is miserable, nobody's sleeping, that just makes everything worse. So if we can provide that baby with some comfort, it's going to trickle up to the rest of the family and everybody will function better. So Dr. Silverberg, just to wrap it up a little bit, let's switch over to Tralokinumab, which is a newer injection medicine for atopic derm.
Sure. So dupilumab, just for background, it blocks the signaling of both interleukin-13 and interleukin-4 because it binds to the receptor that signals for both. Tralokinumab binds to the actual interleukin-13 cytokine. And so it's a little bit more targeted in a sense. It does not inhibit the signaling of interleukin-4. It was approved at the end of December of 2021 and then became available to us, I believe it was in the beginning of March of 22. And we're using it now, and it's become an important new addition for patients. Overall, the efficacy and profile looks very good, and the safety profile is really outstanding. I think the perhaps billion-dollar question that many of us have is how to choose between when to start Tralokinumab versus dupilumab. And I'll be honest, I'm not sure I have a perfect answer for that. I think they're both great options. I think, in theory, one could start with Tralokinumab as a first line. On the other hand, if providers are already, have experience for the past 5 years using dupilumab and they know it well and they're comfortable with the safety and getting it approved and they feel like, why should I switch to something else? I fully appreciate that also. Dupilumab is an outstanding drug.
Some patients prefer something that's been around a little bit longer. If you're giving them the
Absolutely.
two options, some patients say, I'd rather go with what I know. And then some patients would rather take the newer thing,
Absolutely.
I think it varies.
And one thing I will say is where there is a very clear value, in my opinion, is for patients who were on dupilumab and did very well initially, but secondary had a loss of response, maybe due to like auto-drug antibodies or immunogenicity concerns. I've seen those patients do quite well when switched over to Tralokinumab because forming anti-drug antibodies to dupilumab does not necessarily mean it's going to impact the Tralokinumab. It's a different drug. Mm-hmm. Also, for patients who may have had bad conjunctivitis or ocular side effects with dupilumab, while we do see some of those same side effects with Tralokinumab, they tend to be a little bit less severe and a little bit less frequent. So I've seen the number of patients who had those side effects with dupilumab, chose to discontinue, and were able to manage well with Tralokinumab and not get those side effects again. So I think certainly as a second line option and to switch from dupilumab to Tralokinumab is a reasonable strategy for a number of patients.
And when you're questioning patients about their history, when you're putting them on either dupilumab or Tralokinumab, I always ask about prior ocular issues.
The studies have shown that patients who had baseline ocular issues did have more ocular side effects. But on the other hand, I've had patients with some of the worst allergic conjunctivitis, hay fever issues that got completely better with dupilumab. So it's not like every patient who has conjunctivitis is going to run into problems with these drugs. On the contrary. So it's a little bit of a trial and error process. But the good news is for the ocular issues with either drug, 99.9% of the time, they are reversible. We can easily manage them. They don't have to be a reason for discontinuation. We just need to have that conversation with patients and get comfortable managing it. And for the primary care providers out there, if this is something totally new to you, then that would be a reasonable indication to refer. to someone who has experience managing these issues.
All right. Well, I think that just about wraps it up for today. Thank you so much for listening. And thank you, Dr. Silverberg, for this great and informative discussion.